Hello, this is Jacqueline Eckern with Eating Disorder Hope, and today I have the pleasure of interviewing Kim McCaskill with Mental Health Resources. And with that, I would like to introduce you, Kim, and ask if you would share a little bit about yourself.
Yeah, so I'm Kim McCaskill. I'm Executive Director of Mental Health Resources in Memphis, Tennessee. We also have an outpatient line, Mid-South Professional Counseling. Mental Health Resources houses our intensive outpatient programs, and Mid-South Professional Counseling is our just routine outpatient line. So I oversee those programs and work on development and expanding. We're actually very excited to announce that we will start a partial hospitalization program at MHR in the first quarter of 2021. So we're expanding our higher level of care services.
Excellent, very exciting. And can you just tell us a little more detail about your role with Mental Health Resources?
Sure.
Like what your day-to-day is like.
So day to day is, overseeing the team leaders where we have Leah Pinkston, who's our coordinator for our IOP. And Leah is into the day-to-day operations of programming, and she and I consult on, complexities and problem solving, and I help Leah to problem solve anything that needs to be done in the program. And then as far as the program development, I'm always working on ideas. We have ideas to build a specialized obsessive compulsive disorder track for our IOP. Also, we're interested in chronic pain management, not from a medication perspective, of course, but from a counseling perspective. There's a lot of great evidence-based research, such as acceptance commitment therapy, cognitive behavioral therapy, that can be very successful for people with chronic pain conditions. So been working quite a while on trying to develop that, and we're looking into possibly getting into integrated care models in the primary care physician clinics so that we can have very direct access to people with complexities with a medical condition that's impacting their quality of life. So I spend a lot of time thinking of ideas and then trying to bring those ideas into reality.
That's wonderful that
what I'm doing. Yeah.
It's great that you're bringing that creativity all the time and further developing the program as you identify needs in the community. And I know chronic pain is such an issue with really being the underlying issue sometimes behind depression, anxiety, addiction, many struggles. It's so hard to live with chronic pain.
Yes, definitely it is. And in our outpatient line, I help to oversee the kind of the day-to-day at all the facilities. We have site leaders at those facilities who I communicate with regularly to see how things are going. And speaking of chronic pain programming, we want to have everybody in our outpatient line. We want at least some staff members who are able to treat on a routine outpatient level, all of the things that we treat in our higher levels of care. So I'm always working on that as well. Yeah.
Wow. You have an impressive role, a lot of responsibility. So what drew you to enter the behavioral health field to begin with?
So yeah, that's a very interesting question. And when I think way back, well over 20 years ago, I was just taking psychology 101 in undergrad. And I was very interested and I kept feeling drawn to it. I would actually read ahead in the chapters, which was not normal for me. And I thought, well, if this is really interesting to me, perhaps I could make a career out of this. And so I just started signing up for more psych classes. And the more I signed up for, the more I decided that I would declare that as a major. And then once I graduated from my undergraduate program, I realized I wanted to, continue on in an advanced degree, but wasn't sure, I'm more of a research person, maybe neuropsych. And I just kept feeling more drawn to counseling, to that direct client care for psychotherapy. So I entered a master's program for counseling psych, and in 2000 got my degree, and that's pretty much the past 20 years.
Wow. Well, that's exciting that you chose this field because I know you're passionate about it, and we need people that really care and are fascinated by helping people heal in our leadership roles like you have at Mental Health Resources. So What makes mental health resources unique and helpful to those dealing with substance use disorders?
Yeah, that's a great question. The traditional models for substance abuse in most treatment clinics, as you're probably aware, have been strictly 12-step based, abstinence based, that if you're ready to stop, then, we're ready to help you. And that is a wonderful model for millions of people. 12 steps is a great model for many people across the world. However, there's also a significant portion of the addicted population who won't benefit or who are not ready for a 12-step program. And we know that a lot of programs these days who are 12-step based also, do a lot of advertising for motivational interviewing and stage of change. What we see, we're very, very strongly focused on stage of change, and I think that that's what sets us apart. As a matter of fact, when we started our dual diagnosis IOP several years ago, that was part of the specialized carve out that we felt we had in the community, that if people weren't ready to stop, we were not going to turn them away. We were going to meet them where they are in their stage of change. Now, we may know as clinicians that someone needs to stop, but as long as we're making our goals their goals and it's not their goal, it's not going to work. So we feel that we capture a portion of the population who may not be ready to change, but they don't want to go to a 12-step program that's going to tell them you have to quit now, you have to be ready, or you're not doing the work. So we find out what they're ready to do, and we help elicit their own arguments for change, because we firmly believe that inside every addicted individual, there is an internal argument going on every day of their lives, usually operating on an unconscious level, but often it'll peak out at the conscious level, but then it goes back down. What we want to do is put them in our program and keep that internal argument conscious. And the more that we do that, the more we start hearing things like, well, maybe I could cut back from 5 days a week to 2 days a week. What if we just tried that? And a harm reduction model, as far as we're concerned, if you're reducing from a 12 pack of beer a day down to a 12 pack of beer 2 days per week, you're making progress. So keeping people actively engaged is, and through a harm reduction model, is what I feel really sets us apart, because we really do practice that.
Ah, that's music to my ears. I can tell you at Addiction Hope, we helped an individual find some resources for serious long-term alcoholism recently. And the program that they chose to enter was more of a stop now and detox, and then go into 12-step, which I have tremendous respect for, and it works for so many. I think it's a blessing.
Yeah.
However, it doesn't work for everyone, and it didn't work for this one. And so the gentleman, who is a wonderful person but is struggling with addiction for many years, and of course the underlying issues, just wasn't ready for that. And perhaps if he were with you at Mental Health Resources, he would stay in the game, rather than what unfortunately happened is he quit the program, walked out, and is not going back.
Yeah, that's the concern, is that when there's only one way, then there's a significant number of people that get lost. And now there's, someone with addiction out there feeling like I either do this or I do nothing. And that just keeps them entrenched in their addiction. So we certainly introduce 12 steps, we endorse 12 steps, but we do not force it onto them. And sometimes, as people go through the program, we'll actually find that they're starting to go to a meeting or two. Hey, I checked out that 12-step list you gave me. I went to one, didn't like it. Okay, well, why don't you go to another one? What if you shop around a little bit? But we're not going to push it. But some people end up with sponsors by the time they leave the program. So, and some never do the 12 steps, but that doesn't mean they won't be successful.
That's just beautiful, because it's that fluidity, right? That will meet you where you're at. And as soon as you get into this confrontation with people, it's so hard. to be constructive in that, and saying I'll meet you where you're at and work with you is so calming, reassuring, hope inspiring. And it's also beautiful to hear that some of these people do say, hey, I kind of like those spiritual concepts of the 12 step. I certainly like going to the meetings and getting the support and just being authentic and saying, yeah, this is really hard. All of that, there, you create room for that. Whereas if it's forced upon someone, they might just say, I'm just not going to go there at all. So I see the wisdom of that. You mentioned stages of change, and I think our audience would love to understand what those are when they think about their loved one or even themselves struggling with issues. Can you explain that?
Oh, yes. Thank you for asking. So the stages of change model is based on the normal path that all human beings tend to take when we're trying to get ready to change something. So you have a pre-contemplative level in the stage of change. That's the first stage. Pre-contemplation is someone who's not even thinking about change. They don't see there's a problem. Other people may see there's a problem. But if someone were to bring up, hey, Joe, I'm a little concerned about your drinking, Joe is not going to have any conscious understanding that there's a problem. So Joe's going to basically blow it off, have no conscious awareness. And then there's contemplation. So contemplation, just to use the example of Joe, is Joe might start thinking, maybe I have a problem. I don't know. People keep kind of bringing this up. I'm not sure if I have a problem or not. Maybe I do. He's certainly not ready to do anything about it. Now he's a little conscious that something could be going on that he needs to change, but he's not going to do anything about it if he's just contemplating.
Yeah.
And then the next step is preparation. So preparation is where now Joe has had enough time in his addicted world where he's starting to think, I'm starting to have some problems in my relationships. The doctor said my liver enzymes were a little elevated. I'm kind of worried about what this might do to me if I don't do something about it. So he might start looking at some AA meetings online. He might maybe call a counselor, but not show up for the appointment. But he's preparing. He's starting to prepare and really think more seriously that he needs to do something.
Yeah.
And then A is action. Then action is when Joe has gotten to the point to where, hey, you know what? I don't know if I really want to quit, but I'm ready to do something. Or he may have gotten to the point where he's ready to get completely sober. So action is where Joe signs up for support, counseling, a program, and he's taking actual action. He's starting to change some behaviors. Now we know that action is a very vulnerable stage. Joe can very easily stay in action for a month and then very easily go back to pre-contemplation. I thought I had a problem, but once I got into that group with all those other people, now they're the ones that have a problem. I think I was overreacting. Now he's not even thinking about it again.
Yes, exactly.
So we're okay with that. And as counselors, we have to do a lot of internal work to understand that Joe's goals are Joe's goals. All that we can do is help Joe examine his internal argument for change and enhance that motivation that's living within. And so he may have to go out, live some more consequences, make his way back to action. And after somebody stays in action for a long time and they develop a pattern of a different way of life, then they move into the last stage, which is maintenance. And maintenance is where they've pretty much got it down. They just need to stay tuned up so that they stay on that path. But even in maintenance, people can fall all the way back. So we expect as counselors that we're going to see people moving back and forth of the stages of change. And one of the worst things we can do as counselors is get tangled up in arguments with our clients about what they ought to be ready to do. So we work very hard to gauge our own reaction so that if Joe comes back in after 6 months of sobriety and says, I need to come back to the program, but I'm not ready to quit this time, I just want to moderate, we have to understand where is he. And I could elaborate more on stages of change, but that's the kind of snippet of what the model looks like.
Yeah, that's fascinating. We need an article by you or a separate educational video because you just address it so
Happy.
well. And how comforting for those watching, whether it's themselves or the family, to not see this as a black and white issue of, oh, it's over, we're back in the problem, that
Right.
that they could move between the stages of change, and there's always hope in that.
And that really speaks well to the family side of things with this, because it becomes incredibly frustrating with family members and loved ones who often are under the impression of, well, finally, after all these years, Joe's getting help.
Yeah.
Glad that's over. And what the family, really, that education piece for the family needs to be is, this could change, and you need to be able to work on your own resilience and personal growth, in being able to accept that you have no power over where Joe fluctuates. He could relapse. So we try to help them immerse in their own work to help tolerate if he falls backwards, because it's going to be a big disappointment when it happens. It's sad.
Sure, sure. And the statistics show that it can take a while to get in the saddle, stay in the saddle, and then when you fall out of the saddle, do some work to get back in the saddle, and that's okay. I mean, it's not ideal, but it's reality, and accepting that reality is sort of calming, I think,
It's
for the
reality. Yeah,
yeah.
that I really like that you say that. I agree. It's reality that this is how people change, whether they're trying to lose weight after a long-term, weight management problem, or whether they're trying to get sober from a substance, or any other long-term unhealthy habit or behavioral pattern. It takes a long time and a lot of mistakes and a lot of trying to get it right. That's just human nature. So if we can understand that as counselors and clients, that this is part of the human process, we're going to all be a lot better off.
Oh, such good messaging and so hopeful. Do you guys also treat the co-occurring issues, depression, PTSD, anxiety, bipolar disorder, these kinds of things that are really significant in our society?
Yes. So for our IOPs, we have two separate tracks. We have a mental health only track. So if someone does not have an addiction issue, then we just treat the mental health piece, of course. We also have the dual diagnosis track. So if somebody is struggling with addiction and depression, or another mood disorder, or PTSD, we will treat those simultaneously, but also with the understanding that there is a cart horse situation here, and sometimes we may have to work on the addiction piece and get the floor under that first before we can delve into a lot of trauma work, or if they're suicidal thinking, we do have some limits on what we can do with motivational interviewing and stage of change. If somebody is actively addicted, or actively using rather, and they are having suicidal thoughts, then we do have to put a pretty firm line on abstinence at that point, because the risk goes up for safety too much. So we do look at all of those details and treat the co-occurring disorders, the mood disorders, and PTSD and so forth. Yes.
Excellent. And if someone's listening to this and recognizing some of those symptoms in themselves, if they wanted to reach out to you, what website should they go to?
They can go to mhrmemphis.com,
Okay.
and they will see all of our programming that we have available. And the phone number is on there to call directly to leave a message for our intake coordinator, Angel Laughlin. And when they leave a message, Angel returns all calls within a half hour and makes sure that the person gets placed immediately if she is not answering live. There's always a same day return call.
Oh, that's wonderful. And we also have your services listed on the Addiction Hope website. You can find that information there. We have a number that you can call, 844-394-3301, and that goes directly to mental health resources staff that can help you.
Wonderful. Yeah, great.
And then I think I had one other question that I really wanted, well, you touched on it at the beginning, but can you just summarize again what the levels of care are? Because sometimes I'm not sure everyone just generally understands how, can I stay at work? Could I go to school and do this? Can I stay with my little kids, or do I have to go 6 months to a treatment center, you know?
Yes, absolutely. So our lowest level of care is routine outpatient therapy, which means that a person might just meet weekly with a counselor. We also have outpatient medication management. So that's really the lowest level of care, weekly 1 hour therapy and maybe some medication management along with that. And then the next level of care would be intensive outpatient. And so intensive outpatient is 3 hours per day, 3 days, usually about 3 days per week. For people who need something a little more intensive, we can provide 4 and 5 days. We have a morning and an evening option. So if someone needs the 9 to 12 program, if someone needs the 5 to 8 program, we can accommodate mornings and evenings. And very often when people need our intensive services, they are not functioning well at work. So we're very happy to assist them with family medical leave and short-term disability so they can focus all of their attention on their treatment. As we roll out our partial hospitalization program the first quarter of next year, that will be all day, what we call all day programming. So that will take place from about 9 until 3. There will be 6 hours of programming, more intensive contact with the medical doctor and medication management, nursing groups, and things of that nature to have daily programming for a couple of weeks and then step back down to maybe the IOP level of care.
Awesome. So it sounds like people can come in at one level and go up, or step down and have as much support as they need. I know, like in my own experience with eating disorder treatment, the after outpatient counseling for a few years in my case was so helpful. And it's nice that it's all there, that they don't have to go someplace else to get care.
Right. That's really the goal, is to be able to retain people in our services in one place. And in the event that they need inpatient care, we certainly will refer them out to that higher level of care with the understanding they can come back. But between the lower level of care, routine outpatient, IOP, and PHP, people can kind of move as they need to through the different levels of care with us.
That's fabulous. Kim, you are wonderful, and we're really excited about your program and honored to share it on Addiction Hope. Thank you for your time today. And just as a reminder, if you want to reach out to Mental Health Resources or Kim, the phone number is 844-394-3301. And the website again is mhrmichaelharryrobert.memphis.com. It's a beautiful website too. All right. Thank you again.
So much. I appreciate it.